everyone. I'll be presenting the rings and hooks managing subluxated traumatic cataract. There's no conflict of interest and no financial disclosure. Subluxation is partial displacement of lens from the patellar fossa. It could be congenital or acquired as in case of trauma. Management depends upon the amount of subluxation. Up to 3 clock hours of PMMA IOL could be used along with a CTR can be used. In 3 to 6 clock hours, we can use a CTR or a modified CTR with a single loop with IOL implantation. In 6 to 9 clock hours, a modified CTR with a double loop or a combination of CTR or with CTS could be used. In more than 9 clock hours, cataract extraction with SFIOL or ACIOL could be done in same or different setting. This case is of a 9-year-old male child resident of Bhojpur, Bihar, who came with complaint of diminution of vision and whitish reflex from the left eye since 1 year. There was history of trauma to left eye with firecracker a year back. No deviation of eye or floaters or flashes of light was seen. The vision in left eye was hand movements close to face and PL positive and PR accurate in all quadrants. The IOP was normal, facial symmetry was there, extraocular movements were full and free. Orbit, the margins were regular. Lids adnexa, conjunctiva was normal, cornea was clear, but the anterior chamber depth was variable. Iris showed a sphincter tear at 8 o'clock position with wide gape, and the pupil was irregular with mid-dilated with sluggishly reactive. Lens was cataractous with 7 clock hours of temporal subluxation from 6 o'clock to 1 o'clock position. The fundus findings were within normal limit. The right eye findings were within normal limit. Diagnosis of a left eye traumatic cataract with 7 clock hours of temporal lens subluxation from 6 o'clock to 1 o'clock position with iris sphincter tear at 8 o'clock position was made. The patient was planned for left eye phacoaspiration with PCL implantation with capsular tension ring and capsular tension segment. There's a short video. AC entry was done, capsule was stained, capsular excis was done. OVD was injected and the capsular margin was stabilized using capsular hooks and a capsular tension ring was inserted in the capsular bag to stabilize it, followed by phacoemulsification. After which a scleral pocket was made for insertion of anterior capsular tension segment, which was threaded with a 10-0 straight needle proline, and it was inserted in the capsular bag. And the proline suture was exteriorized using a 26 gauge needle, and it was secured by tying the proline suture in the scleral pocket, and the conjunctiva was closed. Post-operatively, the vision was hand movement close to face. The PCIL was in the bag. It was well centered. CTR and eyelids of the CTS could be visualized. Follow-up after 3 weeks. The visual acuity was 6/60. There was centered and stable capsular bag. CTR and CTS was in situ, and PCL was in the bag, but a primary PC plaque was present in the center. Clinical implications: CTR have been successfully used in traumatic cataract with less than 6 clock hours of zonulysis. Fixated capsular tension devices such as Sioni modified CTR with eyelids or a capsular tension segment with eyelids may be required to ensure centration and stability of the capsular bag in eyes with greater extent of zonulysis. My take-home message is, in cases of severe zonular weakness, a CTS on its own does not expand the bag, as well as CTR alone cannot be used to center the bag. This can be overcome by using a combination of the capsular tension segment with the capsular tension ring. Thank you.
Dr. Manjot Kaur. So, what did you do for the posterior segment evaluation?
So for the posterior segment, the indirect ophthalmoscopy was done. It was visible.
And because macula could be affected due to trauma.
Sir, it was visible from the from the zonulysis area. We could visualize the macula and the fundus.
Post-operatively, you should have done evaluated by OCT macula. That would have been better to tell us about the poor visual outcome.
So probably it was due to the primary PC plaque, which was
that is there, but
Dr. Deepti is here.
Manjot Kaur, Deepti.